Hello and welcome to our virtual symposium entitled Achieving Innovation in CLL Care with BTK Inhibitors. During this event, we'll use a tumor board format to explore how BTK inhibitors have changed the management of treatment-naive and relapsed CLL. I'm Dr. William Weirder from the MD Anderson Cancer Center in Houston, Texas, and I'm pleased to welcome my colleague, also from MD Anderson, Dr. Philip Thompson.
Thanks, Bill. Delighted to be here.
Today's agenda is shown here. We will have an introduction to BTK inhibitors as a general class of therapeutics for patients with CLL. We're going to have a tumor board where we'll discuss cases and the role of BTK inhibitors in treatment-naive CLL management. We'll also have cases and review BTK inhibitors in their role in managing relapsed and refractory CLL. And then we will have some postscript discussion around BTK inhibitor combinations, as well as additional future therapeutics for patients with CLL. So let's start with a general introduction to the class of BTK inhibitors and how they're relevant for CLL. Not just CLL, there are other diseases that they're relevant for. We're going to focus on CLL today. This cartoon shows the cell membrane of B cells. CLL cells are B cells, and the receptor on the surface of normal B cells as well as CLL cells is the B cell receptor, which is composed of an immunoglobulin structure. This molecule does come in contact with antigen and will bind antigen, and when there's binding of antigen, there is a downstream effect and signaling that is propagated by several intracellular proteins, which are shown in this cartoon on the far left. Those intracellular molecules transduce this signal through the cytoplasm, and that ultimately results in activation of the B cells that are binding the particular antigen. Those cells will make cytokines, those cells will undergo proliferation, etc. CLL cells have these signaling molecules also in their cytoplasm, just as normal B cells. And the hypothesis is that CLL cells will receive extracellular signals that can be activating and can lead to stimulation and growth of those cells. And there also is some thought that there is constitutive activation of this signaling pathway in these malignant cells. And what we will hear about are inhibitors that block particularly BTK, which is one of the downstream molecules. And by blocking and inhibiting the kinase function of BTK, it will throw the CLL cells into apoptosis and will cause reduction in the bulk of disease and is obviously therapeutic in treating the disease, as we'll see from the data. There are other molecules that utilize these signaling members, such as the CXCR4 on the surface of the B cells, and as well the toll-like receptors. So again, inhibition of BTK in particular for this discussion is important and will sort of starve these cells of their extracellular stimulation. And those cells will then undergo apoptosis, and that's thought to be the mechanism of action for these drugs. This signaling system is important not just for CLL, but for other B-cell malignancies, particularly mature B-cell malignancies like mantle cell. And this slide sort of summarizes those other mature malignant diseases that have been targeted with BTK inhibitors, as well as other B-cell receptor signaling pathway inhibitors. So inhibitors were developed, small molecule inhibitors. The first inhibitor that was developed was Ibrutinib, and that went through clinical development, is now approved both in the US and in Europe. And we saw quite good data and quite encouraging data in the early development of Ibrutinib, where we were enrolling patients who were very heavily pretreated and refractory on clinical trials with Ibrutinib in the phase 1 and early phase 2 experience, and seeing responses in those individuals. We were seeing marked and early reduction in lymph node size, and we were also seeing at the same time a transient rise in white blood cell count, which is what we do see with this class of compounds, and it has to do with demargination and release of those cells when BTK is blocked from the microenvironment. And there have been other drugs in development, one of which has been approved, which is acalabrutinib for CLL as a BTK inhibitor. And Philip will talk about also, I think, mechanism of action in terms of reversible versus irreversible inhibition of BTK. Zanubrutinib, also in development, not yet approved, but is in final phases of testing for approval in the U.S. This is just a cartoon of the structure of Ibrutinib. Again, Ibrutinib was the first molecule that was developed. It binds to BTK, but as you can see on this slide, there are other targets that it binds to, and that contributes to the off-target effects and toxicity effects that we see for Ibrutinib, and others that bind to BTK also may potentially bind to other targets, and that may also play into the toxicities and side effects that we see for those other agents, as we'll talk about. TEC is one, EGFR is another that Ibrutinib binds to and inhibits, and you can see the potentially associated toxicities being, if we're talking about TEC inhibition, bleeding, and perhaps cardiac toxicities. EGFR may result in the GI effects that we see with Ibrutinib or the rash. These are the kinome profiles for enzyme inhibition for 5 of the BTK inhibitors, either approved or in development. As you can see, Acala on the top left, Ibrutinib on the top right. You see several enzymes being inhibited with Ibrutinib in comparison to, if you look to the left, Ibrutinib, where there's a much more restricted inhibition, and perhaps that's why we are seeing some differences in toxicity profile and prevalence of toxicities. These drugs, as I mentioned, have been approved for management of CLL, both in the frontline setting and in the salvage setting, and we'll hear about that data. And that is reflected here in this slide in frontline recommendations in the NCCN guideline and in the relapsed setting, also shown here in the NCCN guidelines. In addition, there are immune modulating effects of these compounds, and that may be relevant in the current era of COVID and the severity of COVID infections that we see. We may be able to modulate that with these BTK inhibitors, and so there are clinical trials that, as shown here, that are being done to evaluate the effectiveness or activity of these BTK inhibitors in patients, not just CLL, but in patients with COVID infection. So that sort of summarizes the background for BTK inhibitors and where we're at with BTK inhibitors. We talked a little bit about off-target being potentially responsible for the side effect and toxicity profile that we see. Maybe Philip, we can start with just a couple questions about, what are the most common toxicities that we see in general with the BTK inhibitors?
Yeah, so thank you. Well, there are certainly some side effects which can be problematic for patients. We often see some joint pain with Ibrutinib that migrates around. Some patients can have rash or diarrhea, although those tend not to be severe. The severe side effects, or potentially severe side effects we see particularly are atrial fibrillation, which can occur in as many as 15 to 20% of patients with long-term follow-up. We also see an antiplatelet effect, so risk of bleeding, and particularly in conjunction with other medications which lead to an anticoagulant effect or an antiplatelet effect. So we have to be mindful of that with co-prescribing and also around the time of surgical procedures or trauma.
COVID is very topical. The last 6 months that we've dealt with COVID has felt like 6 years to me. We get a lot of questions about COVID and the importance of COVID and how we're managing patients. If we have patients that are needing to start treatment, maybe Philip, you can comment on how do we consider in our current COVID era different treatment options, chemo immunotherapy versus BTK inhibitor-based therapy versus BCL2 inhibitor-based therapy.
Thanks. Yeah, I mean, the first thing I would say to that is that I think it's always best to optimally treat the CLL. But if there are several options that are all reasonable, I think in some respects a BTK inhibitor may be the easiest thing to give in the setting of COVID. Many of our patients are not wanting to have a lot of contact with the hospital system because of perceived risk of acquiring the virus by coming and being in contact with physicians and other staff at the hospital as well as other patients. So for BTK inhibitors, they generally require less intensive monitoring and fewer blood tests than, say, for example, Benatuzumab and Venetoclax or chemoimmunotherapy-based treatment. So from that perspective, I think that there are advantages to BTK inhibitors now. There are some theoretical benefits, as you mentioned, that perhaps the cytokine storm that results in lung injury in severe COVID could be attenuated by BTK inhibitors, and there are ongoing randomized studies. So I guess that's another theoretical reason that BTK inhibitors may be useful in the current time.
So let's start with the first case. The first case is a gentleman named Richard. He's a 75-year-old gentleman with a Sears score of 8 and EGFR of 45, which is obviously low. This patient has mild fatigue and dyspnea on exertion. His hemoglobin is 9.5, which is probably contributing to his dyspnea on exertion. His white count is 100,000. Platelets are 120,000. He has a mutated immunoglobulin gene, 13q deletion on FISH, and sequencing shows no abnormality in TP53 gene. He has palpable adenopathy, and by CT scan, the largest node is 4 centimeters. So the patient has RISE stage 3 disease by virtue of having a hemoglobin of 9.5, is symptomatic. Both of those are features that would trigger us to have a discussion about treatment. So he, in my mind, needs treatment. Dr. Thompson, what are some of the things that you are hearing about this patient that help you with directing him towards treatment?
Yeah, thank you. Well, the first thing to say is that he has favorable risk genomic characteristics with mutated IGHV, 13q deletion by FISH, and no TP53 mutations. So based on his genomics, he's someone that you would think would do fairly well with chemoimmunotherapy. However, he's 75, he has a high comorbidity score, and he has impaired renal function. So for all of those reasons, he wouldn't be a candidate for FCR-based therapy. So you could use a less intensive chemoimmunotherapy, or you could use novel agents. As I'll show later, the novel agent-based approaches lead to a longer progression-free survival compared to chemoimmunotherapy in this patient age group and patient fitness. So I'd be looking at a novel agent-based regimen. The approaches would be either a BTK inhibitor plus or minus obinutuzumab, or Venetoclax plus obinutuzumab, and there are advantages to each of those. So the advantages for Venetoclax obinutuzumab in this patient are that he's older, so he's probably at higher risk of cardiac toxicity from BTK inhibitors. He has low risk genomic characteristics, so with a time-limited therapy, you may expect him to have a prolonged treatment-free survival without therapy. On the flip side, he's probably at high risk of tumor lysis syndrome. He has a high white count and he has impaired renal function. So if you were going to use obinutuzumab and venetoclax, you'll have to watch this patient very carefully for tumor lysis. For that reason, you may choose a BTK inhibitor plus obinutuzumab regimen. So I think either of those would be a reasonable choice for this patient.
And do you want to comment on, if you were to give the patient venetoclax-based therapy, the first cycle would be the obinutuzumab?
Yeah, so you know, per the CLL14 study, you know, the venetoclax starts on day 22 after the patients had 3 doses of obinutuzumab, with the first dose split into 2 days. I'd be tempted with the initiation of obinutuzumab in a patient with a white count of 100,000 and an impaired GFR like that to admit the patient and watch him closely for tumor lysis and infusion-related reactions.
So for me, for this case, in the era of COVID and trying to minimize a high-touch experience for the patient, perhaps a BTK inhibitor would be a more reasonable option for him, given that for that category of drug, we're not worried about admitting the patient. We're not as concerned about TLS. They don't have to come back every week for the ramp-up. And they can go on treatment, and we can monitor them as an outpatient with not as frequent of visits for their care.
Yeah, I agree with you.
So the next patient is Alex, a 50-year-old male with a SEER score of 2 and an estimated GFR of 95. Patient has early satiety and a 10% weight loss. His white count is 50,000. Hemoglobin is 12.1. Platelets are 91. Spleen is palpable at 10 centimeters below his left costal margin, most likely contributing to his low platelet count. And he has an unmutated V gene. It has trisomy 12 by FISH and no mutation in TP53 by NGS. So this is a young, presumably fit patient with an unmutated V gene, trisomy 12, who appears to need treatment also by virtue of his weight loss and his thrombocytopenia and his symptoms related to his splenomegaly. So what are the things that you're considering to help direct this patient in terms of treatment?
Yeah, I mean, so this is a young, fit patient that you know, you could give chemoimmunotherapy to, but as I'll show, there are good data now from the E1912 study that show that you get an improved progression-free survival and also an improved overall survival for a young, fit patient with Ibrutinib rituximab compared to FCR. So I would probably treat this patient with Ibrutinib rituximab based on those survival data in the usual setting. Now, the question is whether or not the rituximab is essential. So that study didn't include an Ibrutinib monotherapy arm, but there have been other studies, the Alliance study and also an MD Anderson randomized phase 2, that have shown no benefit in terms of either progression-free or overall survival from addition of rituximab to Ibrutinib. So I think it'd be reasonable for this patient to treat with BTK inhibitor monotherapy. And I think that you know, as you've said, avoiding the high touch back and forth to the hospital, as well as the fact that he has an unmutated immunoglobulin gene, I tend to probably prefer a BTK inhibitor rather than venetoclax or obinutuzumab for this particular patient.
Great. And I think maybe the other comment that I would make is in terms of he's got a very large spleen. The BTK inhibitors are effective at managing patients with large spleens. The BTK inhibitor will shrink the spleen. We usually see more rapid responses in terms of the lymph nodes, and my experience has been that the spleen shrinkage occurs, but you have to be a little bit more patient about that happening, and the nodes will go down quicker. Let's move on to the third case, which is Thomas, a 65-year-old male with a SEER score of 4 and an estimated GFR of 30. His white count is 200, hemoglobin is 8.5, and platelets are 70. He has an unmutated V gene and 17p deletion by FISH. He has a mutated TP53 on sequencing, and he's got multiple chromosome abnormalities on stimulated karyotype consistent with a complex karyotype on analysis. So this gentleman has challenges. He's got poor renal function, a high white count, and all of the features that are high risk in my mind, 17p deletion with mutated TP53 and a complex karyotype. So what are you thinking about management and treatment options for this gentleman?
Yeah, so obviously this patient has extremely high genomic risk disease. The other thing that he has is an impaired glomerular filtration rate, which combined with a white count of 200,000 would make him extremely high risk for tumor lysis syndrome. As I'll show, I think the best data in the frontline setting for 17p deleted patients are with Btk inhibitors. So I would give this man Btk inhibitor based therapy. And then you have to decide whether or not to add a CD20 antibody in this particular setting. The reason that you may want to do it, other than that there's perhaps a better progression-free survival with acalabrutinib or Benatuzumab compared to acalabrutinib monotherapy, is you may blunt the lymphocytosis that will happen as part of initiation of BTK inhibitors, and this patient's starting with quite a high white count. That said, it usually doesn't represent a clinical problem, and it's very rare to actually see hyperviscosity as a manifestation of that. And this patient again has impaired renal function, very high white count, so he would be extremely high risk for tumor lysis syndrome. So my feeling would be probably to manage him with BTK inhibitor monotherapy, watch that white count, and potentially consider adding a CD20 antibody if it became very high, above 400,000.
Yeah, maybe the thing that I would add in this situation is that the obinutuzumab is helpful at clearing the marrow out, and he has cytopenias. I would probably think about adding the obinutuzumab to help clear out the marrow quicker to improve his counts and probably symptomatology. So I don't routinely add CD20 antibody to BTK inhibitor either in the frontline or the relapsed setting, except for in some extenuating circumstances. This might be somebody where I think about it. All right, so let's move on, and Dr. Thompson is going to review for us frontline therapies for CLL, focusing on inhibitors of BTK. So,
thank you. So, we're now in a very fortunate position in the treatment of CLL that we have an array of active therapeutic options, patients generally having excellent outcomes. I've just highlighted the FDA-approved drugs that we have available in red in the frontline setting. So we have several chemotherapeutic agents, CD20 antibodies, rituximab and obinutuzumab, and we now have two BTK inhibitors, Ibrutinib and acalabrutinib, as well as the BCL2 inhibitor Venetoclax. So just by way of background, these are results with chemoimmunotherapy, with FCR in first-line treatment of CLL. So this was a study that began in 1999 at MD Anderson, led by Michael Keating. And you can see very long-term follow-up data shown here. The scale here is measured in years. And you can see that there's a plateau that emerges on the progression-free survival curve beyond 10 years, which is mostly seen in the patients with a mutated IGHV. And these data have been replicated in the CLL-8 study, the German CLL-8 study, as well as a retrospective analysis from the Italian group. So CLL-8 data shown on the left there, and the Italian data shown on the right, showing these plateaus emerging in patients with low-risk genomics. The next the next question that was asked is, well, FCR is associated with several toxicities, most notably some myelosuppression, infection risk, and a 2 to 5% risk of therapy-related myeloid neoplasms. So the question was, well, can we achieve similar results to FCR with a less intensive chemoimmunotherapy regimen like bendamustine and rituximab? So that was the CLL-10 study. And you can see here that the progression-free survival was actually superior for FCR compared to bendamustine and rituximab, although not in the subgroup of patients over the age of 65, which is important when you see some of the clinical trial design that I will show later. Also of note is that the plateau on the progression-free survival curve that we see in the patients with mutated IgHV is really mainly seen in the FCR-treated patients, and which I've highlighted there. That's the green curve, and the red curve, which is the bendamustine and rituximab patients with mutated IgHV. We're not really seeing an emergence of a plateau on that progression-free survival curve. So now I'd like to discuss the use of Bruton tyrosine kinase inhibitors in frontline treatment of CLL. So these are long-term follow-up data from the 1102 study, which was the first Ibrutinib study done in patients. This was predominantly for patients with relapsed refractory disease, but there was also a treatment-naive cohort, a smaller treatment-naive cohort of 31 patients, which is shown in the black. Just briefly, the relapsed refractory patients had a median progression-free survival of 52 months, and this is a group of patients with a median number of prior therapies of 4. So this median PFS of 52 months is similar to what you will see with frontline treatment with FCR, so very impressive results. And obviously the treatment-naive patients are having very favorable outcomes. Now, one thing you need to remember when you're using a BTK inhibitor, though, is it's a very different treatment paradigm to chemoimmunotherapy. So when you give FCR or BR, you give 6 cycles of therapy as tolerated, you stop, you hope you achieve a deep remission that will then lead to a prolonged treatment-free remission during a period of observation. In contrast, with Ibrutinib or other BTK inhibitors, most responses are partial remissions. Most patients will have residual disease when you look in their bone marrow and also in their blood. So you need to continue maintenance treatment indefinitely in order to maintain response. Now, that is important when you think about the potential toxicities associated with these agents in the long term. So these are data from the 1102 study showing just the very long-term follow-up and the cumulative incidence of grade 3 or higher adverse events. So in particular, you see very high rates of grade 3 or higher hypertension in Ibrutinib-treated patients. Now, that having been said, I've very rarely had to stop Ibrutinib because of hypertension. I do highlight it because it's important to aggressively manage it, in my view, as there are some data to suggest that hypertension unmanaged is associated with higher risks of cardiac adverse events. Grade 3 atrial fibrillation or higher in 9% of patients, and that is a relatively frequent reason to stop therapy in patients treated with Ibrutinib. So now I'd like to move on to discussing some randomized studies comparing chemoimmunotherapy to Ibrutinib or Ibrutinib-based therapies in various patient groups as frontline therapy. So the first study I'll discuss is the E1912 study. This was a 2-to-1 randomization to Ibrutinib plus rituximab versus FCR. And in the Ibrutinib rituximab arm, after 6 cycles of Ibrutinib rituximab, patients had Ibrutinib monotherapy until disease progression. These patients were considered FCR eligible on the basis of being under 70 years of age, having reasonable renal function, and not having 17p deletion. These are the progression-free survival curves. You can see that there was a significant progression-free survival benefit for the patients receiving Ibrutinib plus rituximab in both the intention to treat population and eligible patients. The study was not powered for subgroup analysis to look at mutated versus unmutated IgHV, but when the data were looked at, you can see that that the most benefit for the Ibrutinib rituximab group was seen in the patients with unmutated IgHV. In contrast, there's no statistically significant difference between patients receiving Ibrutinib rituximab and FCR if you have a mutated IgHV. Also importantly on this study is the fact that there is a survival benefit for patients that received Ibrutinib plus rituximab. And this was entirely driven by a higher risk of CLL-related death in the FCR arm of the study. There was no difference in sudden unexplained deaths between the Ibrutinib rituximab and FCR arm on this study, with one event in the FCR arm and two in the one in the Ibrutinib rituximab arm and two in the FCR arm. So the next study I'll talk about is the Alliance study. So essentially this was taking an older group of patients, 65 years of age or older. So essentially the group that based on the CLL10 data would be reasonable for bendamustine and rituximab. They were randomized 1:1:1 to BR versus Ibrutinib monotherapy versus Ibrutinib plus rituximab. This study had a crossover design, so if you were randomized initially to bendamustine rituximab and you developed disease progression, you could then cross over to Ibrutinib monotherapy until progression. The PFS curves are shown here, notably a marked progression-free survival benefit for the Ibrutinib-containing arms compared to BR, but notably no difference at all, as I alluded to previously, between Ibrutinib rituximab and Ibrutinib monotherapy. Looking at treatment and disease subgroups, as I mentioned, 17p deleted patients were eligible on this study because at the time Ibrutinib was not easily accessible outside of clinical trials, and there was no difference. There was a benefit for Ibrutinib plus rituximab regardless of whether or not you had 17p deletion or 11q deletion. So the benefit was there in both low and high-risk genomic patients. Finally, I'd like to discuss the Illuminate study. So the initial study that led to Ibrutinib approval in the frontline setting, the Resonate-2 study, compared Ibrutinib to chlorambucil monotherapy, which is a regimen that has modest efficacy. And soon after that study, or really during that study, the CLL11 trial came out showing a survival benefit for chlorambucil obinutuzumab compared to chlorambucil monotherapy. So the Illuminate study was really designed partly as a confirmation of the benefit for Ibrutinib-based treatment compared to chemoimmunotherapy. So the eligibility for this study was essentially you had to be FCR ineligible, so either 65 years of age or older, have significant comorbidities, impaired renal function, or a TP53 abnormality. So patients were randomized to Ibrutinib plus obinutuzumab for 6 cycles, then Ibrutinib monotherapy until progression, or chlorambucil plus obinutuzumab. And again, this study had a crossover design, so if you progressed after receiving chlorambucil obinutuzumab, you could then cross over to Ibrutinib monotherapy. Pre-treatment patient characteristics are shown here. As expected, because of the study design, there was a higher number of 17p deleted or TP53 mutated patients than you would see in an unselected frontline CLL population, with 18% in total. The progression-free survival curves are shown here, and in this slide, it's split up according to IGHV mutation status. You can see the orange curves are patients on the Ibrutinib arm with markedly superior progression-free survival compared to chlorambucil and obinutuzumab. There does appear to be some separation in the progression-free survival curves for the patients with unmutated versus mutated IGHV in the Ibrutinib plus obinutuzumab arm, although this is relatively modest. And this we haven't seen in monotherapy studies with BTK inhibitors, where patients with unmutated and mutated IGHV seem to have similar outcomes. This study did look systematically at minimal residual disease analysis, and it was somewhat higher in the Ibrutinib obinutuzumab arm at 35% in the peripheral blood, compared to 25% with chlorambucil obinutuzumab. So now I'm going to move on to talking about a second-generation BTK inhibitors in treatment-naive CLL. So as Dr. Weirder alluded to, acalabrutinib is a second-generation BTK inhibitor. The point of difference with ibrutinib is mainly that it is a more selective BTK inhibitor, so there are fewer off-target kinase inhibitory effects, particularly less inhibition of TEC, ITK, and EGFR. But it is also a covalent inhibitor that binds to the cysteine 481 at the enzymatically active site of the enzyme, which is important when you consider the most common mechanism of resistance and how to treat a patient that develops a BTK mutation. So these are long-term follow-up data from a frontline acalabrutinib treated cohort, and you can see again excellent progression-free survival outcomes, 90% progression-free at 4 years of follow-up. This looks very similar to the treatment-naive cohort on the initial Ibrutinib trials. So Elevate treatment naive trial was a phase 3 study of acalabrutinib in treatment naive CLL. The patient cohort was similar to what I described in the Illuminate study, in that they had to be 65 years or older or have comorbidities that made them FCR ineligible. The difference here is that 17p deleted patients or TP53 mutated patients were not eligible for the study if they were young and fit. The patients were randomized 1:1:1 to obinutuzumab chlorambucil, acalabrutinib monotherapy, or acalabrutinib obinutuzumab. So the difference here from this study to the Illuminate study is that there's an acalabrutinib monotherapy arm, allowing us to directly compare acalabrutinib monotherapy to acalabrutinib and obinutuzumab. So the progression-free survival results are shown here. There's a marked progression-free survival benefit for the experimental arms. And in a post-hoc analysis, there did appear to be a progression-free survival difference between acalabrutinib obinutuzumab and acalabrutinib monotherapy, although relatively small. And these are the survival data. There is no statistically significant difference yet, but there is a trend with a p-value of 0.057 for a improved survival with acalabrutinib obinutuzumab compared to chlorambucil obinutuzumab. And this will be important to follow up over a longer period of time and see if a statistically significant benefit emerges. Most common adverse events are shown here. I've highlighted a couple. So neutropenia, as expected, was more common with the chemotherapy obinutuzumab arm, and it was more common with acalabrutinib obinutuzumab than acalabrutinib monotherapy. So definitely when you give a potent CD20 monoclonal antibody like obinutuzumab, you will get more neutropenia than you will with acalabrutinib or a BTK inhibitor monotherapy. Headache is a unique side effect of acalabrutinib when compared to other BTK inhibitors. It is generally of low severity, so grade 1 and 2. It's unusual for patients to have to stop therapy as a result of headache. Usually it gets better over time with continued therapy. And there is some anecdotal data that suggests caffeine may be helpful at ameliorating the headache. These are the events of clinical interest on the study, and I'll highlight the atrial fibrillation rates, so 3 to 4%, and that does appear to be lower than what you would expect with ibrutinib in a frontline treated cohort. Also, the rate of severe hypertension appears to be lower than what one would see with ibrutinib. My initial impression is that bleeding complications seem to be relatively similar between the two drugs. So the next question to ask is, can novel agents overcome poor prognosis biology? So I've shown you the importance with FCR and BR of IGHV mutation status, 17p deletion, and 11q deletion. So Resonate-2 data are shown here. So just focusing on the ibrutinib arm of this study, you can see on the left is outcomes in 11q deleted patients. The yellow curve is Ibrutinib treated patients with 11q deletion, and purple is without 11q deletion, and you can see absolutely no difference in progression-free survival whether or not you have 11q deletion. Similarly, unmutated versus mutated IGHV on the right, in the Ibrutinib treated patients, there is no statistically significant difference in outcome if you have an unmutated IGHV compared to mutated IGHV. There's less data in the frontline treatment setting for 17p deleted or TP53 mutated patients because, for example, in Resonate-2 they were ineligible for the study. However, there is a 34 patient cohort in a phase 2 study that was done at the NIH that now has long-term follow-up data, and they were recently updated in a letter to the New England Journal of Medicine. You can see here that they see 6-year progression-free survival of 61%, which is very impressive, particularly when you consider that for FCR-treated patients with a TP53 abnormality, you expect median progression-free survival of around 11 months based on the CLL8 data. Also of note is that among patients with a TP53 abnormality, those with a mutated IGHV appear to have better outcomes than those with an unmutated IGHV when treated with the BTK inhibitor in the frontline setting. What about with acalabrutinib? The Elevate treatment naive study, I think, included 33 patients in total with 17p deletion on the acalabrutinib monotherapy and acalabrutinib Benatuzumab arms. The follow-up is relatively short here, but so far there doesn't appear to be a significant difference in outcome for these patients compared to those without TP53 abnormalities. Likewise, no difference according to mutated or unmutated IGHV at this current duration of follow-up. So important data showing that BTK inhibition in the front line at least partially ameliorates negative biologic prognostic factors. I'll briefly discuss some of the data with Venetoclax Benatuzumab. So these are data from CLL14. You can see in blue the Venetoclax Benatuzumab arm, and in orange the chlorambucil Benatuzumab arm. On the left is outcomes according to IGHV mutation status. You can see there's very favorable outcomes with the Venetoclax Benatuzumab patients who have a mutated IGHV, and although at relatively short follow-up, there's perhaps even a plateau emerging on this progression-free survival curve. Notably, the mutated IGHV patients seem to have a somewhat better outcome with Venetoclax Benatuzumab than the patients with an unmutated IGHV. And on the right, you can see with those with TP53 deletion or mutation, there appears to be a significantly worse outcome for TP53 deleted or mutated patients compared to those without. These are the MRD data from the study. So I bring this up briefly because it's a point of difference between this regimen, which is given for 1 year as a time-limited approach, and BTK inhibition, which is given indefinitely until progression. So if you recall the data from Illuminate, we saw a 35% undetectable MRD in peripheral blood. Here with Venetoclax Benatuzumab, we're seeing 71%. So very high rates of undetectable MRD in blood. You do see, though, when you stop therapy, that there is a progressive increase in the number of patients with detectable MRD over time, which I term MRD relapse. And usually this is a harbinger of subsequent clinical relapse with a lag time of approximately 2 years based on our data post FCR. They also looked at Mrd6 analysis, so this is with next generation sequencing done by Adaptive Biotechnologies, and you see 39% of patients have undetectable MRD at a level of 1 in a million, which is a really deep remission. Most frequent grade 3 or higher adverse events are shown here. Neutropenia is by far the biggest problem with Venetoclax-based treatment, although no difference between the Venetoclax Benatuzumab arm and chlorambucil Benatuzumab arm in terms of the rate of neutropenia. And importantly, there was very, very little tumor lysis syndrome of clinical relevance seen on this trial. So just to summarize, we now have 5 pivotal frontline studies comparing chemoimmunotherapy with novel agents, and they're shown here. They've all shown progression-free survival benefit compared to chemoimmunotherapy. The only one, however, to show a statistically significant survival benefit is the E1912 study, which was Ibrutinib rituximab versus FCR in fit younger patients. There is a trend towards an overall survival benefit for the experimental arm in the Elevate treatment naive study, as I mentioned, and that'll be interesting to watch going forward. So just the other thing I'd like to mention is some patient-specific factors that I use to inform treatment selection. So if patients have low-risk genomics and they're young and fit, I do consider FCR as a reasonable strategy for those patients, because as I showed, there's no survival, no PFS benefit for that group yet in the E1912 study. Venetoclax or Benatuzumab appears to produce excellent outcomes in the low-risk genomic subgroup of patients, so that is a reasonable alternative option, and in particular a good option likely for older patients with low-risk genomics. If a patient has cardiac disease, particularly with a low ejection fraction, or is on anticoagulation, I generally would avoid Bruton tyrosine kinase inhibitors if there's another choice, like Venetoclax or Benatuzumab. If a patient has impaired renal function, and possibly if they have very poor blood counts, then a BTK inhibitor may be beneficial. There is some data when you look at comparison of the adverse events on the Alliance study compared to the E1912 study. Certainly the risk of cardiac adverse events is higher in the older patients with Ibrutinib compared to younger patients. So you may consider acalabrutinib given the seemingly lower rates of atrial fibrillation for those patients. And as I've shown, I think the best data for patients with 17p deletion or TP53 mutation are with BTK inhibitors. So I would generally use BTK inhibitor for that group of patients where I'm not sure that time-limited therapy is necessarily optimal. So how can we do better? I think the novel targeted agents in frontline treatment have really made a dramatic difference to patient outcomes. But I think there are potential opportunities to improve further. So there are a number of studies looking at chemoimmunotherapy-based treatment with the addition of Ibrutinib. There have been 2 studies combining Ibrutinib with FC and Benatuzumab, and one with Ibrutinib plus FCR. And these studies have shown extremely high rates of undetectable MRD, so upwards of 80%, which are the highest rates of undetectable MRD that we've seen with any treatment. And the progression-free survival on these studies is extremely favorable with very few cases of progression. So I think this is an interesting concept to look at going forward. But where a very large amount of development is going at the moment is on developing highly potent, time-limited chemotherapy-free regimens. And these are mostly based on a combination of a BTK inhibitor plus Venetoclax. So there have been several studies with phase 2 studies with Ibrutinib plus Venetoclax showing undetectable MRD rates in the high 60s to low 70s. There's been a phase 2 at Ohio State with Ibrutinib, Venetoclax, and Benatuzumab, which also showed very high rates of undetectable MRD. And several studies with acalabrutinib, Venetoclax, and Benatuzumab. And there are a number of ongoing phase 3 studies comparing these regimens to chemoimmunotherapy and to monotherapy or doublet combinations of novel agents. So I think those will be really interesting to look at in the next couple of years.
We're going to move on to a case, but we got a question in, and maybe you can address this question before I go read the case for the audience. How would you manage a patient with CLL and pre-existing Afib, i.e. avoid therapy or monitor for worsening Afib during therapy? So a patient who has pre-existing atrial fibrillation, how does that factor into how you manage a patient?
If this is a treatment naive patient and they have pre-existing atrial fibrillation, then I would tend to avoid BTK inhibition in that patient, especially if they require anticoagulation. If they don't require anticoagulation, then I don't think it's an absolute contraindication to use a BTK inhibitor. But you would have to, monitor closely. In particular, make sure that the patient is rate controlled with a beta blocker. And then, if they do need anticoagulation down the road because their CHADS2 VASC score rises higher, then you may want to consider stopping the BTK inhibitor. Also, you have to take into account how are they very high risk patient? Are they a 17p deleted patients with complex karyotype, or are they a patient who perhaps has lower risk genomics, where you might expect them to have a very long-term remission after Venetoclax or Benatuzumab? But definitely, I would say it's not an absolute contraindication, but I'd be wary if they needed anticoagulation, and I would tend towards using alternative approaches.
All right, so let's move on to the next case. This is Charles, a 70-year-old male with an unmutated V gene, one prior line of therapy, which was FCR 4 years ago. He started Ibrutinib, and after 4 months on treatment, developed rapid atrial fibrillation requiring an ER evaluation. Ibrutinib was held, and they treated with a beta blocker. They resumed Ibrutinib at a reduced dose of 280 milligrams daily. Again, the patient had recurrent atrial fibrillation. And presumably it was held again, and then the Ibrutinib was restarted at 140, so 2 dose reductions with recurrent atrial fibrillation. Echocardiogram was with a normal ejection fraction, no valvular dysfunction. Patient has hypertension, but no other comorbidities. What's the next step for you for this patient?
So this is an interesting case. This patient has a CHADS2 VASC score of 2, which would usually mean that if he is in persistent atrial fibrillation, you would recommend anticoagulation. So if the patient is in persistent Afib and is on anticoagulation, I would ideally treat the patient with a non-BTK inhibitor therapy, such as Venetoclax, and I'll show some data for Venetoclax in Ibrutinib intolerant patients later. If, however, the patient is no longer in atrial fibrillation and not requiring anticoagulation, the other option for the patient would be acalabrutinib. There's some good phase 2 data showing that the majority of patients who stop ibrutinib because of toxicity are able to tolerate acalabrutinib without recurrence of the toxicity that led to ibrutinib cessation. So that would be a reasonable option, I think, if the patient's not in persistent Afib and on anticoagulation. This is just an illustration of the kind of real-world data that tells you what the most common reasons for cessation of ibrutinib treatment in community practice are. You can see that a median follow-up of 17 months, there were 41% of patients who had stopped ibrutinib. And by far the most common reason for that is toxicity. So the first thing I would say is that managing the adverse events from the use of Btk inhibitors is extremely important, so that you're able to maximize benefit. But there are genuinely some patients who can't tolerate a Btk inhibitor, be that Ibrutinib or another Btk inhibitor, and so we need to have alternative options for those patients. So one potential option is acalabrutinib. As we've mentioned, this is a more Btk specific inhibitor. And as a result of the potentially fewer off-target effects, a phase 2 study was done looking at this drug in patients intolerant of ibrutinib. There were 60 patients enrolled total. They received a standard dose of acalabrutinib after they developed disease progression. Most of these patients were able to tolerate the drug. This is a busy slide, but the most important take-home message is that there were only 7 patients who actually discontinued acalabrutinib due to adverse events. At a median follow-up of almost 2 years, 62% of patients were still on acalabrutinib in this study, with, as I said, 12% withdrawing because of adverse events and 15% because of disease progression. The overall response rate was 72% or 77% when you include partial response with lymphocytosis. And these responses were durable, as you can see from these progression-free survival curves. So definitely this is a potential option for patients with ibrutinib intolerance. The other obvious option for patients who are intolerant of ibrutinib is Venetoclax. And this was a study that was done prior to the acalabrutinib study. These patients were either ibrutinib refractory or intolerant. They were a more heavily pretreated population than in the acalabrutinib study, so median of 4 prior therapies compared to 2. And a very high rate of 17p deletion. You can see the median progression-free survival was just over 2 years, and the response rate was 70%. Importantly, it's important to remember that acalabrutinib is a reasonable option for ibrutinib intolerant patients, but not for ibrutinib resistant patients, because the drug binds to the same binding site on BTK, and patients who develop BTK mutations, which is the most common mechanism of resistance to ibrutinib, would be expected to also be refractory to acalabrutinib, whereas Venetoclax is a reasonable option for patients who are ibrutinib refractory.
So we'll take a question from the audience, which is, in light of the Elevate-TN data, are you now leaning more towards acalabrutinib monotherapy versus acalabrutinib plus obinutuzumab, particularly during COVID?
Yeah, so I think we've alluded to this several times during the presentation, that it's attractive during the COVID-19 pandemic to have a kind of a low-touch treatment regimen, and definitely acalabrutinib monotherapy requires fewer clinic visits, fewer labs, less time in the hospital than acalabrutinib plus obinutuzumab. There is a modest progression-free survival difference in the Elevate-TN data for the acalabrutinib obinutuzumab arm compared to acala monotherapy, but no survival difference. So I think it's very reasonable currently to use acalabrutinib monotherapy, except perhaps in extremely high-risk patients or other individual circumstances.
All right, great. So let's move on to the next section, which is relapsed and refractory CLL. You'll see similar patterns with regard to the data that we're going to review. And the same sort of principles hold, and the observations that we've seen in the front line with targeted therapy in general apply to the salvage setting. The trials that we have available, most of the previously treated patients that are on the available, that have data available in the trials have been previously treated with chemoimmunotherapy. We're moving and transitioning more into a targeted therapy era where previous treatment may be just a BTK inhibitor or a BCL2 inhibitor, and we may see different observations as we move forward with our newer trials for relapse disease. But in general, the trials that we have now, the patients who were enrolled were previously treated with a chemoimmunotherapy based treatment. Let's start with the first case.
Okay, so this is Jane, a 72-year-old lady with a diagnosis of CLL 5 years ago. She had a complete remission with first-line bendamustine rituximab that lasted approximately 3 years, and she now presents with fatigue, night sweats, and progressive lymphadenopathy. She has palpable cervical lymph nodes, but not splenomegaly. But she has a high white count with Rye stage 4 disease with mild thrombocytopenia. Genomics show trisomy 12 unmutated IgHV and wild type TP53. She has an elevated beta-2 microglobulin and a very heavy bone marrow infiltrate. So clearly, I think she meets criteria for retreatment. And Dr. Weirder, perhaps your thoughts on how you'd approach this situation.
Sure. So important features for me is that she's 72 years old. She's previously treated. She's had bendamustine rituximab, had a 3-year remission with that regimen. and needs treatment now. She has an unmutated V gene, so we know that we can get those patients in remission, and sometimes they're MRD negative, but they usually will relapse and will need retreatment. So this patient doesn't have other high-risk features like a 17p deletion or mutated TP53. I should emphasize, though, that if the patient has previously been treated, has progressive disease and needs to be treated again, we do recheck for those things, particularly TP53 mutation analysis and FISH, because patients can acquire abnormalities. And as you mentioned, the patient clearly needs to be treated. For this patient, because the remission was a 3-year remission, they have an unmutated V gene. Today, in the era of COVID, for a 72-year-old, I would most likely be recommending a BTK inhibitor for this patient because of the convenience. And my first choice for BTK inhibitor in this type of patient would be acalabrutinib because of the tolerability and toxicity profile that I have seen with acalabrutinib. That would be my recommendation. It is approved now in the frontline setting and in the relapse setting. I would not be inclined to use a CD20 antibody. So we're going to talk now about treatment for relapse disease, again focusing on BTK inhibitor-based therapy. You saw this slide previously, and it is the longest experience we have with ibrutinib and illustrates paying particular attention to the red curve outcomes for a heavily pretreated group of patients with a median of 4 prior treatments, treated with ibrutinib-based therapy, having a 52-month median progression-free survival. So again, this is a remarkable outcome for a treatment. It is continuous treatment until progression with ibrutinib, but I think fantastic outcomes for therapy in a heavily pretreated relapsed population. There are still high-risk patients, as we've been have been talking about in the relapse setting, and that's illustrated in this curve, which is the same data set, and these patients are identified by their chromosome abnormalities, FISH, and particularly I need to point out and highlight the red curve, which is the patients with 17p deletion having the shortest progression-free survival in the relapsed setting. So in this case, it's about a 2-year median PFS for relapsed patients with 17p deletion. Comparing across trials, which I know we're not supposed to do, if you look at the Venetoclax-based treatment experience in the relapsed 17p deletion group, it's a similar outcome with that treatment in the relapsed setting. So even with the targeted therapy, my point is that we still think about 17p as a high-risk group, and I'm thinking about transplant options for those patients and what my long-term plan is for those patients. The Resonate trial was a trial done in the relapsed setting, phase 3, ibrutinib versus ofatumumab, which is a CD20 antibody, and you can see clear improvement in progression-free survival on the left and overall survival on the right, favoring those patients who received treatment with ibrutinib therapy, with similar outcomes that I showed you for the 1102 experience in terms of median progression-free survival in the relapsed setting. These are data with longer follow-up with regard to acalabrutinib, longer than we have in terms of phase 3 data, which I'll show you in a minute. And this shows you outcomes for patients by cytogenetic abnormalities, and you can see clear activity in patients with 17p deletion, 11q deletion, and also complex karyotype, which has been reported, including by Philip, as a high-risk feature in the era of small molecule inhibitors, particularly BTK inhibitors. So the Ascend trial was a phase 3 trial that evaluated acalabrutinib in the relapse setting versus what was considered standard of care when the trial was initiated. Standard of care gave the treating physician the option, if the patient was assigned to standard of care, the treating physician the option of Idela plus rituximab. Idelalisib is a PI3 kinase inhibitor, is approved in the relapse setting with Ibrutinib, or physician choice of BR, bendamustine rituximab. So the provider had the option to choose either Idela rituximab or BR, and as you'll see in the curves, most of the providers chose the targeted therapy, Idela plus R. A minority of the patients in that control arm received BR. Acalabrutinib was standard dosing, 100 milligrams BID. You can see on the left progression-free survival by treatment arm with improved outcomes for those patients in the red curve who received acalabrutinib versus those patients who got control treatment in the blue curve. And as I mentioned, most of those patients are patients who received Idela plus R. And you can see the control arm split by treatment. Green indicates the BR assigned patients, and blue indicates the Idela-based treatments. And similar outcomes between those two treatments for the control arm. Activity in those patients with 17p deletion being similar in terms of progression-free survival as those who don't, among those patients who received acalabrutinib on the left, and also similar outcomes by mutation status in the red curves for patients who have mutated versus unmutated V gene who received acalabrutinib. And that's a similar observation as we saw in the frontline setting as Philip showed. This is a longer-term follow-up for the Murano trial. Now, the Murano trial evaluated Venetoclax rituximab versus BR in the relapse setting. And this is here just to illustrate what the expectations might be from fixed duration 2-year Venetoclax plus 6 months of rituximab in the blue curve. Again, in the relapsed setting, having a 4-year progression-free survival of 57%. We see similar profile and distribution of toxicities and side effects among the relapsed patients. We do see a bit more toxicities in the older group. We don't see really a difference between frontline versus relapse. We do expect frontline patients to be on these targeted therapies longer than the relapsed if we're talking about continuous and indefinite treatment. And again, I think the important thing here is to remind people that patients can acquire high-risk features, 17p and TP53, so we should be retesting for those features, and that can alter how we manage these patients. So that generally summarizes the relapsed data we have for BTK inhibitors. We have an audience question about resistance to BTK inhibitor-based therapy. And the question is, when do you test for mutations in BTK? Philip, do you want to comment on resistance to BTK inhibitor-based therapy and when we might be evaluating for mutations in BTK?
Yeah, thank you. So by far the most common resistance mechanism to Bruton tyrosine kinase inhibitors is the development of a point mutation at the cysteine 481 binding site, most commonly a C481S mutation. That results in loss of ability of ibrutinib or acalabrutinib to bind covalently and effectively inhibit BTK. So the importance of that mutation is that essentially it results in resistance to all all covalent BTK inhibitors. So if you have that in a patient, you need to be thinking about switching therapy. Now, when would I test for it? Well, essentially any patient that appears to be developing clinical resistance to ibrutinib, so a rising white count or increase in lymph node size. So if they appear to appear to be developing clinical failure. So then, if someone was found to have a C481S mutation, the options would be to switch to Venetoclax, and that's been shown to be effective at treating patients with that mutation, with a median progression-free survival as I showed of about 2 years. The other option is to look at a clinical trial. There are two potential clinical trial options that you could look at in a patient with a BTK mutation. The first is with a reversible BTK inhibitor. So these are allosteric inhibitors that bind to a different site on the enzyme and appear to be unaffected by C481S mutations. So they seem to work just as well in those patients as with wild type BTK. So one of the most promising agents in that class is LOXO305, some data of which were presented at ASH last year by Anthony Mato. And very encouraging toxicity profile. This is an extremely targeted BTK inhibitor, so very few off-target kinases are inhibited. And in 28 patients, no DLTs, no maximum tolerated dose identified, and also responses in all of the patients with a C481S mutation so far. So that would be an option. The other thing to consider is CAR T cells. Generally, my personal approach is to reserve CAR T cells for patients who are double refractory, so refractory to both Ibrutinib and Venetoclax. Just because the toxicity profile of CAR T is generally more serious than with Venetoclax. That said, there have been some dramatic and long-lived responses to CAR T therapy. So the first patient that was treated at the University of Pennsylvania for highly refractory CLL is still in remission 10 years later and is probably cured. So that's an exciting field to watch going forward.
Here's another question. So for a patient who received first-line treatment with Venetoclax or Benatuzumab, as in CLL14, if the patient progresses, would this patient respond to subsequent BTK inhibitor-based therapy? And is there data that would support that expectation?
Well, yes, that's a good question. So unlike the reverse situation where there's robust data with Venetoclax treatment after failure of BTK inhibitors because there was a specifically designed clinical trial, in this setting, I'm only aware of data that's been presented in abstract form with relatively small numbers of patients. But there's certainly no theoretical reason why patients would not respond to BTK inhibitor after failure of Venetoclax. My first approach, if a patient receives frontline Venetoclax or Benatuzumab and then develops disease progression, is to assess how deep was their remission and did they progress while on therapy or within a short time after stopping therapy, because that patient is very different and is likely to be Venetoclax refractory to a patient who maybe had a MRD negative response and then 3 or 4 year treatment-free interval before developing disease progression, and because that patient could well respond to Venetoclax retreatment. But to answer the question, there is some small case series which show that most patients who are Venetoclax refractory will respond to a BTK inhibitor, but less robust data than the reverse order.
And I would add that my own experience has been that I have treated several patients after frontline Venetoclax-based therapy with a BTK inhibitor and consistently have seen responses in those patients.
Yes, likewise.
So thank you, Philip. Thank you, and have a good day.
This activity has been jointly provided by Penn State College of Medicine and PVI, Peerview Institute for Medical Education.